when, where, and how. When, in terms of indication, where to do it, high tibial, distal, femoral, intra-articular, and how to plan and how to do it. Before starting, if you have a patient who's 48 years old and who has knee osteoarthritis and pain and not responding well to conservative treatment, what would you do? Who will continue conservative till total knee? Anyone? Who will do arthroscopy requirement? You will do arthroscopy. Who will do total knee replacement justified by severe symptoms? Anyone? Okay. Who will do osteotomy or advise him to do osteotomy? So stay with me. So we'll see after the end of this talk. Okay. Now, osteotomy around the knee, when we have indication, and all of us know that it's indicated correct deformity, but also it is indicated to offload a disease compartment, like osteoporosis, osteoporosis, condylar lesion after mastectomy, especially those patients who have pain after mastectomy. And not only that, it is indicated to off-stretch a diseased ligament. So if you have stretched ligament, osteotomy may be indicated to off-stretch, especially in those patients with varus hyperextension thrust and posterolateral instability. And we have combined indication, like many of these indications. Now, the indication decide your plan. So whether to correct or correct. Where to shift the mechanical axis. I need only correction in normal knee, or I need to overcorrect in diseased knee. So this is given our indication and our plan. Our aim is to shift the mechanical axis to the neutral, this case, or to the normal side. This is in terms of deformity correction. But it's very important to do it in the right way. Why? Because sometimes you have a straight limb, like in this case, this young patient has bilateral varus deformity. The surgeon correct on the left side, somewhat second correction. But if you see, the joint line is oblique. So all the correction was at the proximal tibia, and the result is that oblique joint line and shearing forces, which we all know that this may lead to osteoarthritis. So how to avoid this? We need to plan to do high tibial, distal femoral, this double osteotomy. This is according to our plan. So let's take this example. This is a young patient who has varus deformity, and if you see the mechanical axis is involved. Now the question, to do high tibial or distal femoral? Many of you think that all varus high tibial. No, we need to plan, to do measurement, and in this case, you see that the varus deformity is the femoral side. The MLDFA was about 100. So in this case, we decide to do distal femoral osteotomy. So we do simulation, make measurement, define the site and degree of correction, and then go to the surgery. Some technical tips that if you do closing wedge osteotomy, you have to start with the guide wires, make the first cut, then measure how many millimeters the base of the wedge. After that, make the other one. Make sure that you preserve the hinge. If you see here, this is the hinge. If it is thick, you can weaken it by osteotomy, and then gradual correction of the osteotomy, and after that, you can check the alignment and fix with the edge. So this is before, this is the plan and this time. And we do most of the time biplanar osteotomy. If you see here, it's a biplanar osteotomy. And this I'll talk about the benefit of biplanar osteotomy. This is before and this is after. This is another case of varus, but in this case, the patient has double deformity. So this is the femur and high tibia. So for this, it's not enough to do single osteotomy because the result will be oblique joint line. So in this case, we need to do double osteotomy. Now, what not to miss? Surgical plane deformity. So this patient, you see how the tibial slope is more than 30 degrees. This is very important, and especially in ACL. If you have patient with ACL failure, you have to check the slope because this is maybe a major cause of failure of ACL reconstruction. So in this case, we plan the osteotomy, make simulation, make the measurement, and after that, we draw it down, In this case, we decided to do double wedge osteotomy to have one contact, and then after making a plan, you can go to the surgery and do the operation. You see here how the slope is corrected. Now, is it high tibial, distal femoral, double osteotomy, or it may be intra-articular osteotomy? This is especially in complex cases, like in this case, plant disease. You see, after we make the plan and analysis of what the problem we have, we make a plan, then after that we go to the operation. In this case, the patient needs intra-articular osteotomy, and in later stage, we did for him high tibial osteotomy closing bridge. This is before, and this is after correction. So always do a plan to decide your site and degree of correction. Why I started with deformity? Because the same principles apply in the treatment of knee disease. Because the second indication is to offload a diseased compartment. And this is very common in our practice. Either osteoarthrosis, pain after mastectomy. You see a lot of patients with pain after mastectomy. Raise hand. I see a lot of patients who has virus. So we have to think of mastectomy in treatment of these patients. Now, knee osteoarthrosis, condyle lesion, pain after mastectomy, osteonecrosis. So we have different indications, and this is also, we may apply it, I think you agree with me that to protect autograft or allograft, like osteochondral allograft or meniscal allograft. So it has extended indication. So in knee osteoarthrosis, which patient? We prefer to do osteotomy in young patient, active, manual workers, or those involved in sports activity. And it's not advisable to do it in a obese patient or in advanced disease, but still there is power for that. And all that, the patient should have undesirable malalignment. So if the patient has needed osteoarthrosis and followed us, this is good. So it's already have osteotomy. Now, what's the relation between deformity and osteoarthrosis? We know from the literature that each 4 degrees of malalignment can increase the risk to develop osteoarthrosis by 3 to 4 times. And this patient, if developed osteoarthrosis, so he has a risk for progression by 10 to 20 times. So you can see how the malalignment affect the course of osteoarthrosis. So what happens if we do this? If we shift the mechanical axis from medial to lateral, what happens? And this study, this is a laboratory study by Professor Philippe Dobelhofer from Hanover and Jens Education. They showed that when we shift the mechanical axis from the 0 line here, if the mechanical axis here, the load would be about 2/3 on the medial side. And if we shift it to this point, where it's called the Fujisawa point, or 62.5%, the load will be in the other way. It will be around 2/3 on the lateral side. So by osteotomy, we know that we are offloading the diseased compartment. So we improve the symptoms, and most important, also we delay the progression of osteoarthrosis and delay the need for total knee replacement, especially in young active patients. So to do or not arthroscopy for doing osteotomy, I will do always, because most of the time I have something to do, like treatment of condyle lesion, microfracture, meniscal pathology, and very important to make sure of the lateral compartment, which I will overload it, so it should be normal. And this is very important, because root tear, the video is of, always check. I think we have covered that, but this is very important because I see a lot of patients with root tear which was not apparent by MRI. So all my patients, when I do osteotomy, I probe the root, because sometimes you look it's good, but when you probe it, it's apparent. So we have to do arthroscopy to make sure of the lateral compartment, and after that, to do our procedure, to repair and to do our procedure. Now, you see, this is repair, combined procedure, repair and osteotomy. Now, back to our patient. Who will do osteotomy for him? Who will do? Okay. This is very ideal clinical indication, young, moderate osteoporosis, varus, and chronic pain, limitation of function and walking distance, and not responding well to conservative treatment. This is a very typical indication for osteotomy. So in this patient, after plan, we did for an tibial osteotomy. But not always tibial osteotomy. Look, this case, where she has bilateral osteoporosis, on the right side we did double osteotomy, and on the left we did tibial. So this is according to the plan. So always plan is important. And this is a case of combined indication. This is the other indication. We have, like this case, deformity and osteoporosis. Now we have other indication. Offloading, off stretching a diseased ligament. Let's take this example. This is a basketball player. She has no trauma, but gradual onset and somewhat progressive posterolateral knee pain. When I examined her walking, you see how she has varus hyperextension thrust to the right side, and her pain is posterolateral. But the Dale test was not so much significant, so I don't think she will benefit from ligament reconstruction. So for her, we did long term and found that she has some varus with osteotomy. And this is only 5 months after the operation. It's almost normal alignment and no more thrust. Okay, other indication in instability. This is in patellar instability. I think we have talked about that. So either rotational osteotomy or maybe distal femoral osteotomy, varus osteotomy with combined maybe with or without tibial osteotomy. So there is a rule for osteotomy treatment of patellar instability. And combined indication. Look to this case. This patient has previous 2 or 3 surgery for posterolateral cord, and he still have pain. At the same time, still has instability. At the same time, he has varus and osteoporosis. And he's young, manual worker. What to do? The best is to plan for osteotomy. You see here the ligament is about. So we do the planning and did for him osteotomy. So by osteotomy, we did offload the diseased medial compartment and no more stretching of the lateral ligament. So, is it to do open wedge or closing wedge osteotomy? Before it was almost closing wedge, but we have problem with that. The muscle dissection, the need for fibular osteotomy, the step which can result from closing the wedge, and this may interfere with future prosthesis. And the more concern is about the coronary nerve, which is more common than we believe in these type of procedure. On the other hand, open wedge osteotomy, no muscle dissection, no fibular osteotomy, and no shortening, no peroneal nerve problem, and important that we can fine-tune during the operation. So if we do plan, and we say, okay, inside, we check the alignment, standard correctly, we can fine-tune the osteotomy. But it's not safe, because we have problems like loss of fixations with arthrosis, slope changes, and sometimes the need for bone graft. But with the development of the techniques, this is no more major problem. The introduction or the doing the osteotomy by biplanar osteotomy provide a lot for this procedure because it increases the surface area, rapid healing, and provides stability. And also, we are now doing gradual open wedge osteotomy to preserve the hinge. Like Philippe Oberhofer says, top to bone, just open it slowly, and we preserve the hinge. The third, that we use plate osteokinesis with, which is internal fixator, locking the plate, and this provides early stability in the period. And we have more concern about the slope changes. So by biplanar, you see you have rapid, you have larger surface area for healing, and you see this is only 3 weeks. This is by Philippe for 3 weeks only after the osteotomy it was healed. So rapid healing and more stability. And with the use of these plates, you don't need a graft even when you do more than 12 or even 16 millimeter open wedge. Now, if you know these advanced techniques and follow the principles, you can allow your patient to do early full weight bearing, early range of motion, no braces, and so you can do biplanar osteotomy, bilateral osteotomy, and even more advancement in the technique to do minimal invasive techniques. You see here, it's only small incisions. And if you know all these, I think you will think of osteotomy in a different way. Like, take this example. example. This is malalignment after teasal of anything. So if I ask you to plan osteotomy, most of you will think to do this. Yeah, it's right. The corner and the closing wedge at this. It's right. Now, if I want a hinge and I want biplanar osteotomy and I don't want to do fibular osteotomy, I may plan it like this. So if you see here, we plan it the same. We do the osteotomy and we compress both the plate, the alignment, compress the hinge. You see, this is for compression of the hinge. Here the hinge is very well compressed. We do biplanar osteotomy, you see here. So by this we can allow the patient for early weight gain and for early range of motion. And here post-op, you see the alignment. And all these we cannot achieve if we do like this. So take home message, osteotomy is indicated and has an important role in the treatment of knee pathology, either osteoarthrosis, chondral lesion, or instability. Always do pre-operative planning to decide the site and degree of correction. Biplanar osteotomy is very excellent improvement in the technique for rapid healing and more stability of the reconstruction. And always try your best to preserve the hinge and respect and follow principles. Thank you.
We are inviting now